Okay, cool. So I'm sorry this is purple, but I think it does change. So yeah, this is ophthalmology. So the first part will be done by myself. I'm Amar, and then you've also got Emma, who will be doing the second part. Um, okay, so we can just go straight into it. So what we'll cover today is kind of the main topics in not all of them, but it is pretty much all you need to know for ophtha. It's not too much because it is only a week long, I think. So this won't take you too much. Um, but yeah, so the first one we'll go through is, yeah, and if you guys have any questions, please just ask. Go ahead. Okay, so first of all is conjunctivitis. So this is essentially inflammation or infection of the conjunctiva, which is that transparent membrane covering like the white of the eye. And so there's two types really. So back to, well, it's three types. So we've got bacterial, viral, and allergic. We'll go through allergic in a bit, but so so you get some kind of similar symptoms in both. So it's like the redness, the irritation, the itching, the excessive tearing. But the main difference between the two that you help distinguish between the two in like an SBA scenario is that in bacteria it is purulent discharge and might mention things like the eyes are stuck together. But in viral, it's more like a watery discharge, and it might mention something about like a recent upper respiratory tract infection, and also get like pre-auricular lymph nodes. So these are both clinical diagnoses, but with bacterial, you may want to do a swab, um, but usually they go straight to the management. So yeah, so bacteria is mainly caused by strep pneumonia and Staph aureus and Haemophilus influenza, but you should also consider STIs such as chlamydia and gonorrhea. So like I said, for bacteria, you do want to give topical chlorphenicol, but in pregnant women, use topical fusidic acid. But with viral, it is purely just it's self-limiting. It will go away on its own. And other advice that you can give is don't wear contact lenses, don't share things like towels, and you don't need to exclude them from school. That can sometimes come up in like an SBA. Okay, and yeah, so this is allergic conjunctivitis. So this is the most common form of conjunctivitis. It's a type 1 hypersensitivity reaction. So it's things like caused by things like pollen, dust, and like pets. And the difference between this is you'll realize that this is usually bilateral, but the viral and bacterial is unilateral most of the time, but they can be bilateral. But to differentiate, this one usually have like a history of ATP, so like have history of asthma, eczema, hay fever, and usually seasonal as well, because like summer you get hay fever. So the main management for this is obviously to avoid the allergens, give topical antihistamines, and second line, but you don't really need to know this to be honest, is like mast cell stabilizer. So sodium chromoglycate, and you also get it's called nedocromil. Yeah. And also other subtypes of allergic conjunctivitis. So you got that seasonal one, was that hay fever, perennial one caused by allergens like dust mites. But you don't really need to know this. That part is kind of too niche. But you can get like chemical and irritant conjunctivitis, and that in that case it is a ophthalmic emergency. So that's urgent irrigation to your eye and urgent referral straight away. And you see on the right hand side here, it's like lid findings. So what you'll see in the eyelids. So bacterial and allergic, you'll see this papillae, and in viral, you'll see more follicles. But again, it doesn't really come up. Okay, so other eyelid problems that I'm talking about, and this can get quite confusing, I find, because they kind of all overlap. So you get blepharitis with chronic inflammation of the eyelid margins, and it's the most common cause of dry eyes. So it can be due to infection, but most likely you'll see it in like non-infectious causes. So especially seborrheic dermatitis usually comes up in questions, and rosacea. So you kind of get that bilateral, painful, gritty eye, itchy eyes, and this can cause secondary conjunctivitis. So again, it's like bilateral because if it's seborrheic dermatitis or non-infectious causes, usually are like autoimmune. And so you get that erythema of the eyelid margins and the crusting at the eyelid margins. So the management is again supportive. So hot compress is like your kind of go-to. And you want to, it's dry eyes, so you want to keep them moist. Use artificial tears, and again, don't use contact lenses as well. Um, so another thing that comes up commonly is a sty. Um, it's like a staph infection. You get an abscess. So this is exactly what it looked like. And again, it's just hot compress over the eye because this can become blocked and leads to a chalazion, which we'll go through next. But it's just you don't really use antibiotics, but you can sometimes use topical antibiotics, but that's only if there's conjunctivitis. And it's just, but it's again just warm compress and analgesia. A chalazion is a kind of cyst, almost like like a firm, painless lump in the eyelid. So again, it can be caused by a sty if it's left for too long, and mostly it's just reassurance. So this will resolve on its own, but rare cases you might need to do like surgical drainage. And so this is an important topic. So orbital cellulitis and preseptal cellulitis. So this is important because orbital cellulitis is a life-threatening condition, and this needs to be recognized early on. So especially like GP or ED. So the difference between the two is that orbital cellulitis is an infection that involves like the deeper structures. So you'll get that limited eye movement and proptosis, but preseptal is like literally what I described as preseptal. So it's superficial tissues are affected. So it's anterior to the orbital septum. So they'll usually have like similar symptoms. So the edema, the erythema is unilateral, but the difference is with preseptal, you ask them to move the eyes, they are able to move it perfectly fine. There's no pain or anything like that. So with preseptal, it's not life-threatening. So, but you do give oral antibiotics because it can progress to orbital cellulitis. But if you have orbital cellulitis, it's an urgent referral to ophthalmology. It's admit for IV antibiotics, and you possibly need to do a surgical decompression as well. Just because it can cause things like meningitis, abscess formation, and cavernous sinus thrombosis. So again, these are very life-threatening conditions. And if you're always in doubt, do a CT orbit with contrast. So you can see like the fluid building up there. Okay. And some corneal conditions that you need to know about. So you only need to know them very briefly. It's just mainly identifying them because you have eyes, and if you lose them, you're not going to get another one. So corneal abrasion, a defect in the corneal epithelium. So usually like a local trauma. That's abrasion. And ulcer is a defect, usually secondary to infection. So keratitis can cause this. So you can get bacteria and fungal keratitis. So this is usually in someone who's like wearing the contact lenses in the shower, at night, etc. And this can cause an infection and can lead to a corneal ulcer. So what you want to do is tend to stop wearing the contact lenses, give topical antibiotics, or if it's severe, and give topical antifungals for fungal disease, but it's usually bacterial. And but you can have also viral keratitis caused by HSV, varicella zoster virus as well, and this can lead to a dendritic ulcer. I think there's a picture we got of a dendritic ulcer coming up, so we can have a look at that. But kind of the symptoms are similar to conjunctivitis, actually, like that eye pain. We also get a photophobia, watery discharge. And it's that kind of gritty sensation that I've got something in my eye, like a foreign body. Yeah, and you can also get acanthamoeba keratitis. So it can look like viral keratitis, but on the slit lamp, it does show a ring-shaped corneal infiltrate. So that can be like a buzzword in questions. But it is just kind of oral NSAIDs for pain, topical steroids, topical antibiotics. Okay, and yeah, okay, so this is the dendritic ulcer that I was talking about. So if it says dendritic ulcer in SBA, then it's going to be herpes simplex ulcer, like pretty much all the time. So that's what you see in that slit lamp. And they do like a fluorescein staining, and you see this kind of green dendritic ulcer. And so HSV keratitis is actually the most common form of corneal blindness in the developed world. So again, it's the same symptoms: the red painful eye, the photophobia, and you also get that reduced visual acuity. It's an immediate referral to Opthal with a topical acyclovir. Again, stop the contact lenses because that's like the risk factor for it. You obviously wouldn't be expected to prescribe steroids in this situation. It's only done under like ophthalmologists, so you wouldn't give them in this situation. Another important thing is herpes zoster ophthalmicus, and this is a kind of like shingles, like a reactivation of the varicella zoster virus in the cranial nerve 5 of the trigeminal nerve, and you get that vesicular rash around the eye. And the main thing that you'll see in like SBAs is like the rash at the tip of the nose. That's called Hutchinson sign. If it says that, it's herpes zoster ophthalmicus, and so it's this immediate referral, antivirals started within 72 hours because it can spread to your eye. So that's what they're worried about. Okay, so we got our first SBA. So a 21-year-old female presents to her GP with a one-day history of itching and watery discharge from both eyes. On examination, the vision is 6 out of 9 in both eyes. Both pupils are equally reactive to light. The conjunctivae are both chemos with mild diffuse injection. The eyelids are slightly edematous. Her medical history includes eczema. Her vital observations are as follows. So I can give you guys a few minutes to, well, like 30 seconds to think of an answer. And if you're watching it, you can pause it and come up with an answer. Okay, so the answer for this one is allergic conjunctivitis. So like I said, look for like key buzzwords in the SBA. So they have a history of eczema, so it's like um, atopic. So that's gonna point you towards like an allergic conjunctivitis. Again, it's bilateral. So it's discharge from both eyes. So it's unlikely to really be like bacterial or viral conjunctivitis. There's nothing um, really mentioned about kind of that infection. Like it's not hot, it's not swollen, it's just her eyes that are discharging. So you're not really worried about ultracellulitis. Doesn't have that pain or movement of the eyes. Like there's only slight edema. Like in like the cellulitis, you'll get more edema, more redness, more swelling. Um, They'll be a lot less stable. Like from the obs, they're pretty much stable. So yeah, that's kind of the difference. So red eye. So taking a history. So it's kind of similar to that Socrates. So when was the onset? Was it sudden? Was it gradual? Where is it? Is it one eye or both eyes? Due to pain, if it is pain, against Socrates, the key red flags you want to look out for is visual disturbances. So is it more blurry? Do you see like flashes and floaters? Do you see halos? Is there photophobia? What about meningitis? If you have nausea and headache, is there a history of trauma? Those are the main red flags we want to look for. Like if they do have an Oscar station about like a red eye, then this will be really important. Um, so other associated symptoms, so that itchiness, that grittiness that you might see in the keratitis, like we said, that swelling, that eye discharge. If it is discharge, what color is it? Is it because you want to know if it's like bacterial conjunctivitis is like that purulent discharge, but viral conjunctivitis is that watery discharge. You need to know what the difference. Are there contact lenses, and if they are, go through how often they wear it, how often they change it, how they clean it. Do they wear it in the shower? Do they wear it at night? It's just you're looking for risk factors for these conditions that we talked about before. And again, just your normal systems review, because a lot of these eye conditions can come up like overlap in other conditions. So it's not just ophthalmology, it can come up in rheumatology especially, and also with GI, and because if they have IBD, you can get things like uveitis. If you have axon, rheumatoid arthritis, SLE, you can get like uveitis, scleritis, things like that. And when examining, always check for papillary reflexes. So yeah, like I said, scleritis. So there's scleritis and episcleritis. So the difference between the two is basically scleritis is inflammation of the sclera, and this is like at the outer layer of the eye, like that clear outer layer, and this is very painful, deep pain. You get that photophobia, you get that watering of the eye, and like I said, it's associated with rheumatoid arthritis. So you might see it like in rheumatology questions as well. So the reason why we worry more about scleritis and episcleritis is because scleritis can cause ocular complications such as peripheral keratitis. It can cause uveitis, it can cause cataracts, and it can cause glaucoma. So that's why we do refer urgently to ophthalmology. You want to give NSAIDs or steroids, so prednisolone. And if they have rheumatoid arthritis, you can give cyclophosphamide or azathioprine. And then episcleritis is inflammation of the episclera. So that's like the layer between the conjunctiva and the sclera. And this is more of a common benign and self-limiting condition. So not really worried about this one too much. But again, the difference, because you need to differentiate between the two, is that pain. So episcleritis is no pain, scleritis there's pain. Yeah, so episcleritis again, associated with rheumatoid arthritis and Crohn's. So again, it's differentiating between the two, similar to like the orbital cellulitis and the preceptal or preceptal cellulitis. Like it's important to differentiate because one's dangerous, one's not. Okay, and again, this is a dangerous condition as well called anterior uveitis. So it's an inflammation of the anterior portion of the uvea. So this is the iris and ciliary body. So here you get acute onset pain, red eye. So it's again that really important here. And what the key thing here is the pupil is irregular and small. That's like the main kind of buzzword you'll see in SBAs and the differentiating factor. And you get photophobia, but you do get normal acuity, like they can see normally, but this does get impaired with time. And you can get something called a hypopion, which is kind of like a bit of kind of you can see like a fluid when you do like a slit lamp. And it's kind of that's made up of white blood cells and like debris. So yeah, investigations and slit lamp examination. So I don't know if you guys have done your ophthalmology placement yet, but you'll see them do it. And you might see this. So yeah, you get that inflammatory cells in the anterior chamber. So you get that hypopion, you get that adhesions between the lens and the pupil. And so because I said it could be life-threatening, well, threatening to your eyes, it is an urgent referral to ophthalmology. And you want to use cycloplegics such as atropine to dilate the pupil, and you want to stop the photophobia. Give steroids because it's usually associated with other conditions, like I said, like ulcerative colitis, ankylosing spondylitis. So all like the autoimmune conditions. You want to treat this underlying disease. So like we said, is it is it reactive arthritis? Is it IBD? And then because, like I said, you want to treat this because it can cause vision loss due to macular edema. Okay, and again, another big one is acute angle closure glaucoma. So what happens is essentially you get buildup of fluid in your eye called the aqueous humor, which is produced by the ciliary body. I don't have a picture of the eye, which would have been useful actually, but you kind of look up a picture of the eye. So you have the ciliary body, which produces the aqueous humor. This flows through the pupil and it leaves the eye via the trabecular meshwork. And this is that trabecular meshwork is like between the cornea and the iris, like where they meet. But in angle closure glaucoma, the iris blocks this angle, where the trabecular meshwork lies. So you get a buildup of this aqueous humor. So you get this rise in intraocular pressure. And this can cause damage to the optic nerve. So that's why you get painful blurred vision, reduced visual acuity, and halos around lights. So that's like a key buzzword again. And you kind of get that nausea and vomiting as well, systemically unwell. Um, so there's signs on examination is that you get that red eye, fixed and mid-dilated pupil. That's quite hard because of that fluid buildup. It's a hard palpation, and you get that corneal edema. So you do a tonometry, which will sense a high intraocular pressure. And you also want to look at the angle that we talked about where the trabecular meshwork is. Okay, and management for this is that you want to use beta blockers. So it's timolol. This reduces the aqueous production. You use topical pilocarpine. This increases the outflow of the fluid, and IV acetazolamide to reduce production of it. So reduce production and increase outflow. And obviously, don't forget about supportive management, the antiemetics and the oral analgesia. And the definitive treatment is a bilateral laser iridotomy. So it's like a laser that creates a hole in the iris, so allows fluid to basically escape if the angle gets closed again. Okay, and so the next thing is subconjunctival hemorrhage. So again, like it's the classic picture of like this red eye. You might have a small patch of like we can still see the whiteness of it, but the red kind of takes up a lot of the eye. And it's a rupture of superficial vessels. This is very common, caused by things like trauma, rubbing of the eye can cause it, or a rise in like intrathoracic pressure, so the coughing, the vomiting, heavy lifting. It's usually people who have hypertension and are on anticoagulants. So they're usually asymptomatic. It's just that red eye, but patients are usually worried about it because it's like, oh my God, it's a red eye. But this is just like kind of reassurance. It's conservative management because it does self-resolve, but it can give lubricants if it does feel kind of gritty. This is a more severe condition. So endophthalmitis. So this is infection of like the eyeball itself, the globe. So it's usually so it can be caused of things like corneal infection, eye trauma, but the main thing is, oh, a patient had surgery, and now they present like a red swollen eye, really painful, can't see out of it, hazy cornea and that hypopyon. Again, that same thing that we saw in the anterior uveitis. So this is more severe because um, it can cause visual loss. So send to theatre ASAP, and you want to use IV antibiotics as well. Sorry, intravitreal antibiotics. Okay, so the second SBA, an older male presents with an intermittent frontal headache associated with pain around his right eye, which looks slightly red. He describes episodes occurring while he watches television in the evening, during which he sees halos around lights in the room. On examination, there is no tenderness around his temporal artery, and his eyes appear normal. He has normal visual acuity, and what is the most likely diagnosis? Again, give you a few minutes for that, or 30 seconds. Okay, and the answer for this is acute angle closure glaucoma. So the reason is, again, like I said, look out for those buzzwords, halos around lights in the room. That is like, tells you that it's glaucoma, but it's also this symptom. So he's got that frontal headache. He's had kind of episodes before, but now he's got that really bad pain. So not anterior uveitis because, again, remember I said his eye appears normal in this one, but on visual on examination of the eye in anterior uveitis, you get that irregular pupil. And with tension headache and giant cell of arthritis, you would get that tenderness around the temporal artery. Okay, and yeah, okay. Okay, so cranial nerve palsy. So this is the three. So for the eye, there's three that's applied. So the oculomotor, the trochlear, and the abducens nerve. So the three you need to know about. So with third nerve palsy, so oculomotor, you get that down and out pupil, ptosis, so that kind of closure of the eyelids, and you also get pupillary involvement because, and you can read this in your own time, but these are the muscles that the oculomotor nerve innervates. So basically, the only ones that are going to be, if the oculomotor nerve is out, then the only ones that are going to work is the trochlear and the abducens. So you're going to get eye going down and lateral, so down and out. Yep. Okay, and you can also get ischemic third nerve palsy. So this is without pupillary involvement, and it's usually patients with diabetes, hypertension, like risk factors like that. And these are more benign and just resolve spontaneously. You also get compression as well. So this is pupillary involvement. Can be due to mainly tumors, is what tumors and other space occupying lesions, and these are need urgent evaluation, urgent referral because it can cause permanent, like life-threatening complications. Okay, so again, so this thing about all of these, so what they innovate, and so if they're not working, then what happens? So, like I said, so the trochlear moves the eye down. So that's not gonna if it's not gonna if that's if that's a fourth nerve palsy, then eyes gonna move upwards, isn't it? So they get vertical diplopia, and this it causes the patient to develop an unconscious head tilt because they're trying to look down, but they can't. Okay, and the sixth nerve palsy is abducens nerve. So this moves your eyes laterally, so it might cause the eye to be immediately deviated. So like in this picture. So Horner syndrome is something that comes up a lot, like in SBAs. So the triad you need to know is ptosis. So again, that closure of your upper eyelid, meiosis, so small pupil, and anhidrosis, so that's like no sweating. So you usually get like usually it's because of a pancreas tumor, kind of the apex of the lungs. But there are other causes, so it can be so post pancreas tumor is actually pre-ganglionic, but you're also going to get post-ganglionic and central causes as well. But this difference is so pancreas so pre-ganglionic will have anhidrosis of the face only, so you won't be sweating at all on the face. Um, but post-ganglionic is no anhidrosis whatsoever, and but central causes you will have anhidrosis of the face, arm, and trunk. So no sweating face on the trunk or the arm. Um, okay, and you got a Holmes-Audi pupil. So it's a neurological condition, which is in large people that react slowly to light, and it's most commonly you see in the SBAs. It's like a woman who's like 35 years old. And the underlying pathophysiology, you don't really need to know this, to be honest. It doesn't really come up. It's not really doesn't come up a lot, to be honest, but it's like a damage to the ciliary ganglion, which is the postganglionic parasympathetic fibers, which cause papillary constriction and accommodation. And it also is associated with, you might see like absent ankle and knee jerk reflexes. And we also get the Argyll-Robertson pupil. This is like seen in neurosyphilis, was like so I don't know if you've done your sexual health yet, but it's like a stage tertiary syphilis, late later symptom. The mnemonic that you can use for this is ARP, so accommodation reflex present, but pupillary reflex absent. So ARP and PRA. So that's a small irregular pupil. So that's different. That's how it's different to Holmes-Audi pupil. There's no response to light, but there is a response to accommodate. So yeah. So again, it usually says, oh, they have untreated syphilis or something. Okay, and SPA 3. A 35-year-old woman presents with photophobia and enlarged left pupil, which had a delayed and incomplete constriction to light. Accommodation was relatively normal. A pilocarpine test was positive, and a focused neurological examination specific to the presenting symptoms, not to reveal any abnormalities. So again, I'll give you about 30 seconds for this. Okay, and this is what we just talked about. So this is Homey's Addy pupil. So it's not going to be Horner syndrome because that doesn't have the triad that we talked about, the ptosis. This is a enlarged pupil. Horner syndrome will have this meiosis, so the smaller pupil. It's not third nerve palsy because like we talked about, the down and out eye, that's what will give it away, but there is none of that here. Okay, so there's that 35-year-old woman with enlarged pupil. Cool. So that's the end of my part. I really appreciate you guys can fill in some feedback for me. But yeah, guess you guys can have a 5-minute break, or Emma is gonna do the next part. She could just.
Yeah, I'll give you a 5-minute break and leave that up so that people can do some feedback before I start.
Cool. Thank you. Okay. Cheers, guys.
Yeah, so we'll start again at 6:40, 6:42. Actually, would you guys rather just push straight on, or up to you? Happy to give you a break. Just give you a few minutes then.
Well, straight on's fine with me.
Straight on's fine. Okay, cool. All right.
Okay, I'll stop sharing and then you can start sharing.
Yeah, sounds good. Okay, can everyone see the slides?
Yeah, we can. Yeah.
Okay, perfect. So moving on to the second half of kind of the main opthal presentations, you've got all the sort of red eye, but there's also loss of vision. And loss of vision can sort of be split into kind of two main halves. You've got sudden loss of vision or a more gradual loss of vision. And again, you can get some that are sort of unilateral, bilateral, but depending on the description, you can usually tell what kind of condition you've got. So talking through some of the sudden onset loss of visions first. And the first one is central retinal artery occlusion. And it's relatively rare. And it's usually from sort of an embolism from either AF or some sort of carotid atherosclerosis. Or you can get arteritic from temporal arteritis, and it's pretty sudden onset, painless, and you get this sort of unilateral visual loss. And sometimes patients have a RAPD as well, relative afferent pupillary defect, and they also get sort of a loss of visual acuity, and they might have carotid bruits or AF depending on the sort of cause behind it. Okay, so the main risk factors for this are hypertension and diabetes. Oh, whoops. But you've got to consider GCA as a diagnosis because it could be temporal arteritis. And obviously then sort of risk factors for that would be SLE, polymyalgia rheumatica, different conditions that can give you GCA. It's quite difficult to manage, and it generally has quite a poor prognosis, but you tend to manage it by managing the underlying causes. So treating GCA by giving steroids and sort of managing complications. So you can do sort of intervene to try and manage any potential complications. The other thing to remember with central retinal artery occlusion is that you can't drive for a month, and they have to inform the DVLA. So like having a TIA or a stroke. And yeah, you can give ocular massage to dislodge the thrombus, but generally there's not really a huge amount you can do. Some debate about whether you can give alteplase in the first 24 hours, but still in trials and hasn't really been approved or anything yet. On fundoscopy, so you can see on the right a picture, this is kind of key spot diagnosis, lots of that in ophthal, and the sort of cherry red spot is the classic central retinal artery occlusion, and you get this sort of like pale retina around it. But early on it might look completely normal, but this is the sort of classic central retinal artery occlusion on a fundoscopy. So if you've got any questions at any point, just stop me as we go. But otherwise, we'll move on to retinal vein occlusion. So kind of similar, you've got a thrombus that's occluding either the central vein or one of the branches. And risk factors similar, but main risk factor being age. And over 65, they've got a worse prognosis. But any kind of hypercoagulable state or atherosclerosis. And the classical sort of fundoscopy sign is these sort of flame hemorrhages or stormy sunset. And they can be sort of different. They can look slightly different. It doesn't always look classically like this. So it's worth just flicking through a couple of images to try and get those spot diagnoses. But again, it's sort of conservative management, no actual treatment to reverse it, but you can manage the complications by giving like anti-VEGF for any macular edema or pan-retinal photocoagulation if you get neovascularization. Some recovery, but again, there's quite a poor prognosis for retinal vein occlusion as well. And if you look on the fundoscopy, sometimes you just get partial stormy sunset, which is if you have a branch retinal vein occlusion. Okay, so the next big one is ischemic optic neuropathy. And this is when you get poor blood flow to the optic nerve rather than sort of a blockage of the artery. And there's sort of two main types. You can either get the anterior or posterior, but more sort of importantly, you can get arteritic causes, which caused by GCA, or non-arteritic. Most common is non-arteritic anterior, but they're all sort of medical emergencies. And the symptoms, again, of arteritic, the symptoms are of GCA, so headache, They might have had a fever, but jaw claudication, scalp tenderness. And then investigations, you want to look at the ESR and CRP because that should be raised in GCA, but also look with the slit lamp and temporal artery biopsy if you're thinking GCA, but that should be done within 2 weeks. And the important thing to remember with temporal artery biopsy, which has sort of been over, that you can get skip lesions, so negative on a temporal artery biopsy doesn't necessarily rule out GCA. So the ESR is sort of like the key thing that will indicate that in terms of investigations. It's associated with central retinal artery occlusion and branch retinal artery occlusion, but the management is urgent steroids. So you want to give high dose prednisolone. Usually you give high dose IV methylprednisolone, tends to vary by hospital, but sometimes they give oral prednisolone, but in general, high dose IV methylprednisolone for ischemic optic neuropathy. And then once you've got it under control, you can sort of carefully wean down the steroids over a few weeks. So then this is sort of the classical, what you might see on fundoscopy, you get a sort of swollen optic disc. It might look a bit pale, and you might also get RAPD as well. And you can sort of see the arrows pointing to the little notches in the artery, the lots of vessels. So next there's posterior vitreous detachment and retinal detachment. And these are largely very similar, but there's a few sort of differences between them. So posterior vitreous detachment is when the vitreous membrane, which is the sort of like bit that lies against the retina, detaches from the retina. And the main risk factor of this is age, because as you get older, the vitreous fluid gets less viscous, and also myopia, because the shape of the eye is such that it's sort of more prone to pulling away. And it's more common in female than male. But the main symptoms of this that you get is you get the sort of floaters and flashes, then they get blurred vision and sort of cobweb appearance across the vision. And when you look at the fundoscopy, the picture below is of retinal detachment, but on fundoscopy, the sort of classical sign is a Weiss ring. And posterior vitreous detachment can progress to retinal detachment. So it's really key that you have an urgent opthal review to rule out any sort of retinal tears that may lead to a retinal detachment. But if there's no retinal tear or detachment, then symptoms tend to resolve at around 6 months. So retinal detachment is quite similar because you get the same sort of flashes and floaters and loss of visual acuity. But the main difference is that rather than getting sort of cobwebbing across the vision, you get this sort of veil or curtain coming down. Both of these are painless as well. But you can get, with retinal detachment, you can get a sort of retinal tear that progresses to a retinal detachment. And that's usually from some sort of trauma, but it can be diabetic retinopathy, or sort of lots of different factors. But again, sort of risk factors are age, myopia, but this one's more common in men than women. And there might be a family history there. The only other thing is that on a slit lamp examination, you might get Schaeffer's sign, but the key thing is just to visualize the retina and look to see sort of the number of tears and see if there's a vitreous hemorrhage as well. These two are sort of quite difficult to tell apart. So in reality, if you're suspecting either of them, you need an opthal review so that they can look with a slit lamp and see what's going on. And so if there is a tear, they can do laser photocoagulation to prevent detachment. But if there has already been a detachment, then they can do a vitrectomy. But sort of complications are you can get sort of complete visual loss. And if you have detachment with the macula as well, it's got a very poor prognosis. So you can kind of see on the left the sort of like curtain coming down of the retina detaching on fundoscopy. And this is the sort of key sign that you get. And if you look up some pictures of like retinal tears, you get sort of tiny little, it literally looks like tears. It's quite straightforward. Any questions on any of that so far? Otherwise, we'll just go on to vitreous hemorrhage. So vitreous hemorrhage is a little bit similar, but different in that the main sort of cause or indicator risk factor is diabetic retinopathy. And posterior vitreous detachment can progress to vitreous hemorrhage. And any sort of like retinal breaks and retinal detachment are the sort of most common causes. Other causes, but much less common, are ischemic retinal vein occlusion, wet, ARMD, or SAH. And this is when you get a sort of bleed into the vitreous humor. So you can see on the right, this sort of like pools of blood, which causes damage, and that's what gives them this sort of like loss of sight. And they also get a sort of red hue generally, with like blurring of vision and floaters. So these three are your sort of key ones if anyone comes in with floaters. And they may have a sort of absent red reflex, but it sort of depends on the severity of the vitreous hemorrhage. And if you have a chronic vitreous hemorrhage, there might be sort of like a yellow lesion from the hemoglobin breaking down. So again, you want to do fundoscopy, slit lamp, and you're looking for any retinal tears. And if it's small, it can be managed conservatively. But if it's sort of really dense and large, you might need to do a vitrectomy, or you can do laser photocoagulation as well. So the last one before we do an SBA. So optic neuritis is when you get inflammation of the optic nerve, and it's really strongly associated with MS. I think it's like 20 to 30% of people who have MS, the first presentation is with optic neuritis. So have a really strong sort of index of suspicion for investigating. And less commonly, it's also associated with lupus and syphilis. So obviously known MS is a risk factor, but it's much more common in women than men and tends to be much younger age. I'm not sure why it says that the incidence is higher in latitude countries. I'm not sure. But you get the sort of unilateral visual loss. But the key thing here is that you get pain that's worse on eye movements. So just making sure to always ask about, is there any pain? Is the pain on eye movements? Because that can help you distinguish what's causing the visual loss. And the other thing that they sometimes put in SBAs is that you get this reduced colour vision, or sort of like red desaturation with optic neuritis. And sometimes you get an RAPD. So in terms of investigations, because you are sort of suspicious that there may be some sort of MS, you need to do an MRI, brain and orbit, to show the optic nerve, and also sort of try and look for any other white matter lesions for MS. And you just give high dose steroids, and generally there's quite a good prognosis, but it can recur in the same eye or the other eye. And it usually takes about 4 to 6 weeks, but generally the prognosis is quite good. So just an SBA now. So this is a 70-year-old female presenting with sudden unilateral painful loss of vision, present on waking this morning. She's known to be hypertensive, controlled with ramipril and amlodipine. Current blood pressure is 155/80. Pulse is 84 and regular. She takes statin for primary prevention. Her lipid levels have been satisfactory. The changes found now on fundoscopy in the affected eye is shown. So I'll just give you a few seconds to look at the fundoscopy and And if you want to put it in the chat or just talk out loud, happy to make it a bit more interactive. Okay, so the answer to this one is central retinal vein occlusion. So even though it looks a little bit different to the other picture, you can still sort of see that stormy sunset kind of look. And obviously it'll vary person to person, but this is quite a classic central retinal vein occlusion. So loss of vision obviously isn't always sudden. Sometimes you get sort of this more gradual onset loss of vision. And the most common cause of sort of gradual onset visual loss is age-related macular degeneration in the sort of developed world. The key things to distinguish between with age-related macular degeneration, you've got dry ARMD or you've got wet ARMD. And they both look different and have different pathophysiologies. You get fairly similar symptoms, but the sort of risk factors are largely similar. But with dry ARMD, you get these drusen spots, so dry drusen. But with wet, you get this neovascularization that kind of leaks fluid. That's why it's called wet and dry. So the main symptoms are you get this sort of blurring of the central vision, and the vision gets a bit distorted, and metamorphosa sort of means like distortion of the shape of objects. So one of the tests that is quite good for this is looking at Amsler grid, and you can look up pictures of them, but it's literally a grid, and if you put it in front of someone with ARMD, they get this sort of like warping of some of the squares, and that's quite telling. So in terms of investigations, you want to do retinal imaging, fluorescent angiogram, and main sort of stay of management is encouraging people to quit smoking because it's quite a big risk factor, and particularly when it's wet ARMD, they sort of need to stop ASAP. And also you can give antioxidants, but for wet ARMD you can also give anti-VEGF. So I know Amar spoke about acute angle glaucoma before, but primary open angle glaucoma or chronic open angle glaucoma is the sort of degeneration of the retinal ganglion cells that leads to this irreversible loss of vision. And the main risk factors are diabetes and myopia. I think it's also more common in Black patients than white patients and sort of varies by ethnicity. But peripheral visual loss is the most common sort of first symptom, and they get this like tunnel vision. And on fundoscopy, you get sort of, they call it cupping of the optic disc. And it's where the kind of cup to disc ratio is more than 0.7. And you can, it's a shame there's not a picture here, but if you look up at a picture of it where they've drawn the lines on, you can see quite clearly how the ratio changes with open angle glaucoma. So management, they now offer selective laser trabeculoplasty. First line, if the intraocular pressure is higher than 24 millimeters of mercury. But then second line, they give topical beta blockers, so things like timolol, and which decreases aqueous sort of secretion and production, and topical prostaglandin analogues, so latanoprost is an example of that. And that works by increasing the uveoscleral outflow. And then also topical alpha-2 agonists like brimonidine which work by sort of doing both, and carbonic anhydrase inhibitors like acetazolamide, which decreases secretion. And with these drops, it's quite good to know the class of them, what their action is, and any sort of contraindications or side effects. So timolol as a beta blocker is contraindicated in asthmatics and people with heart block. And then latanoprost can also give like side effects of excessive eyelash growth and brown pigmentation of the iris. So sort of good side effects to know and things to warn patients about, so that they don't get scared, or if you have an SBA or a patient coming in, you can sort of explain different side effects and know which ones to use. And then also they can have surgery as well. So cataracts is the leading cause of curable blindness. So whereas ARMD is the leading cause of uncurable, whatever the word is, blindness. And this is when you get sort of gradual opacification of the lens. And the main risk factor is aging. Just as you get older, the lens gets cloudier, but smoking, diabetes, and steroids are also key risk factors. So, and steroids is one to really remember here. So in terms of symptoms, you get reduced vision, faded color vision, and this sort of like glare and halos around lights. So if patients say they're sort of driving at night and looking at lights, they get this sort of glare. That's quite classic of cataracts. And ultimately surgery is sort of the gold standard and works really well, and it's usually quite a quick outpatient procedure. But the thing to remember with the surgery is that really important complications, if you have anyone coming in with eye problems having had recent surgery, you can get posterior capsule opacification, or endophthalmitis is sort of nasty infection, but also you can get retinal detachment. So key in any history, just seeing if patients have had any previous cataract surgery. So diabetic retinopathy is something that I'm sure you're aware of, having done endo and renal. And it's something that's screened for yearly in all diabetics over 12. And there's a whole sort of classification system of it. But the sort of key things to know is that it's split into proliferative and non-proliferative diabetic retinopathy. And in non-proliferative diabetic retinopathy, you get these sort of microaneurysms, hard exudates, cotton wool spots, sometimes sort of hemorrhage as well. Whereas proliferative diabetic retinopathy, you get proliferation of new blood vessels. So the treatment for both of these is laser photocoagulation and anti-VEGF as well. In severe cases, they might do a vitrectomy, but it's sort of good to have a bit of an understanding of these because it's something to counsel patients on, particularly patients coming in for a diabetes checkup. And it's also quite an important complication in terms of sort of impact on patients. Okay, I'm not going to go through this in loads of detail, but another sort of complication of systemic disease is hypertensive retinopathy. So depending on the features, you can stage hypertensive retinopathy. Again, the main sort of stay of treatment for this is prevention and just trying to have really good blood pressure control. So it's a good idea to have a sort of an understanding of the different stages if you want to. Sometimes you get sort of questions asking you to stage it, but it is quite specific. And just having an idea that you get this sort of silver wiring in stage 1, and then stage 2, you get this sort of arteriovenous nicking, which can then progress to sort of more cotton wool exudates and flame blot hemorrhages. and sort of stage 4 is papilledema. So another SBA, I'll let you guys read this one and give you a few seconds to just think about it. Okay, has anyone got any guesses for the answer on this one? Okay, so the key thing with this question is just seeing his blood pressure. 191 over 127 is really high. So the most important thing to do here is to treat that high blood pressure with IV labetalol. And then hopefully the symptoms should settle, and then just sort of maintaining good blood pressure control. Okay, so you may have touched on some of these if you've done peds, but in terms of like pediatric eye conditions, retinoblastoma is the commonest malignant tumor in children. It's usually diagnosed about 18 months and it's got a really good prognosis, particularly if it's caught early. And there are some sort of mutations that are associated with it, but the main clinical feature of this, which you look for in the NIPE exam on newborn babies, is leukocoria, so white pupil. And any white pupil, you want to be thinking retinoblastoma and ruling that out. Sometimes they can also present with a squint, maybe if they've got reduced vision, but the mean age of presentation is sort of 8 months to 25 months. So because they're really young, the main thing you're going to notice on examination is the leukocoria. So in terms of investigations, you want to do an ultrasound or an MRI. Don't necessarily need a biopsy. But usually there's surgery, chemotherapy, all sorts of phototherapy and external beam radiotherapy, but overall has a really good prognosis. Genital cataracts is the other one to be aware of, and there's some sort of syndromes and chromosomal abnormalities that it's associated with. And also sort of infective, so like torch and syphilis, that require urgent opthal assessment because you've got risks of amblyopia and squint. So squint or strabismus, for the medical term, is when you get misalignment of the eyes. So it's really important to correct, because if you don't correct it, it can lead to amblyopia, which is medical term for lazy eye. And you can either have a convergent or a divergent squint. So the most common is concomitant, which is when you get an imbalance in the extraocular muscles. And you can detect the squint by doing the corneal light reflection test to see if it reflects symmetrically in the pupils. And to determine the nature of the squint, you do the cover test. And if necessary, they might need referral to secondary care. But the mainstay of treatment of this to prevent it progressing to amblyopia and treatment of amblyopia is you put a patch over the weaker eye, over the stronger eye, sorry, which forces the weaker eye to work sort of harder. And that ultimately improves the muscle, whether it's the ocular muscles that are causing the problem or whatever the cause behind it, it forces the weaker eye to work harder rather than just letting the dominant eye take over. And if you don't treat it, the sort of dominant eye will just work harder, and the other one, the weaker eye, gets fewer and fewer signals and ultimately stops working. So quite important to treat this as soon as you can. And sometimes they put atropine drops in to reduce acuity in the stronger eye, which is sort of the similar sort of theory behind just patching the eye. But also children with this would need referral to secondary care. Okay, so we've got a 3-year-old child with a suspected squint, who's referred to the ophthalmologist by her GP, and she's diagnosed with amblyopia and suggests occlusion therapy. Which of the following best describes occlusion therapy? Okay, so hopefully you've had a bit of a think about that one and got an answer. So yeah, like we were saying, the occlusion therapy is when you cover the normal eye with a patch, which forces the weaker eye to work harder. So that's the end of the second half. Sorry if I rushed through that, but I think there's quite a lot that you sort of just have to go over. If you could fill out any feedback, that would be really helpful. Thank you very much. And hope you have a good evening.
I'm sorry, can I